lesion that you see in sarcoidosis, lupus pernio, and how do you make diagnosis of sarcoidosis? Transbronchial biopsy is the method. And what is the common metabolic abnormality in sarcoidosis? Hypercalciuria. And long-term steroid alternative agent which you use is azathioprine is what you need to ultimately remember. Now, doctor, with regard to sarcoidosis, what is the false statement is the favorite NEET PG question. NEET PG 2014. Yes. Please punch on the video so that you can be able to listen the voice. Keep punching your answers, doctor. Is the broadcast fine? Yeah. Good. Very good. It is the pleural effusion is uncommon, but there's an elevated angiotensin converting enzyme in sarcoidosis. Similarly, bilateral parotid enlargement is the feature of the sarcoidosis. And which facial nerve is involved most commonly? It is the facial nerve, cranial nerve 7, which is involved. And basically, it is the lupus pernio, which is often asked as an image-based MCQ. Similarly, sarcoidosis can involve the heart. That's the reason ECG 2D echo will show the restrictive cardiomyopathy pattern, which you see in the case of the sarcoidosis is what you need to remember. Of all the organs, which is the most commonly involved organ in sarcoidosis, is the favorite question. Yeah, you can take you can take short videos and then put in the group. Yeah, just short, like yesterday, short videos. So, which organ is most commonly involved in sarcoidosis? You need to remember, it is the lung. Yes, very good. Dr. Shastri and Satvik are absolutely right. It is the lung which is involved. Now, what is the ocular manifestation which is very common in sarcoidosis, which is vision threatening in nature, uveitis? And why there is a hypercalcemia in sarcoidosis? Because all those macrophages keep overproducing vitamin D-like substance is what you need to remember. And what type of granuloma is a sarcoid whenever you do histology? It is a non-caseating granuloma is what you need to remember. And the most sensitive investigation to know the cardiac involvement in sarcoidosis is cardiac MRI is considered to be the investigation of choice is what you need to remember. Idiopathic non-specific interstitial pneumonia typically shows which pattern? Come on, punch your answer, doctor. Typically, interstitial lung diseases is one of the top favorite topic of the NEET PG examiner. Idiopathic non-specific interstitial pneumonia. Typically, where do you see? So, it is the Haman sign. Nobody could answer. Satvik and Shastri, both of them missed it. Yeah. So, let us see. Non-specific interstitial pneumonia. There is a uniform interstitial inflammation. And it is the subpleural sparing under the pleura. Sparing is considered to be the favorite feature. Then on HRCT, you find ground glass appearance is what you need to remember. Then there is a UIP, NISP. Between the two, NISP generally has got a better prognosis. We give corticosteroids, and it is a restrictive lung disease that you see in case of NISP is what we should remember. Micropolyspora fini is classically implicated in which hypersensitivity pneumonia? NEET PG 2015 question. One confident answer, doctor? Yes. Can you please ask Mary and to inform each of them? Yeah. Yes. Micropolyspora fini is classically implicated in which hypersensitivity pneumonia? It is the farmer's lung. Satvik and Shastri, both of you are clean bowled, right? Now, let's quickly master some of the facts. Hypersensitivity pneumonia, what is the type of hypersensitivity? Type 3 and 4. And typically, we do the precipitants, antigen precipitation test in order to identify. And chronically, hypersensitivity pneumonia, what is the complication, doctor? Fibrosis. And if you do bronchoalveolar lavage in hypersensitivity pneumonitis, it will be predominantly with lymphocytes. And whenever bird proteins are there, right, then the occupational exposure is because of the thermophilic actinomycetes is what we should remember. Bilateral hilar lymphadenopathy, negative MAN2 test, because both TB, sarcoid, both of them are both of them are granulomas. TB is caseating granuloma. Sarcoid is non-caseating granuloma. So you need to differentiate between the two. So, doctor, let us see. What's your answer? So, yes. It is the sarcoidosis, classically. Satvik is absolutely right. Yes. It is the sarcoidosis. So the minimally invasive diagnostic investigation of choice is transbronchial biopsy. And it is the 7th cranial nerve which is involved in sarcoidosis. And methotrexate is the first line steroid sparing drug. And cardiac involvement is very common. And closest to differential diagnosis is a caseating granuloma, which you see in case of TB, is what you should remember. Right? Now, what is the metabolic disturbance which is commonly associated with the sarcoidosis? Is the favorite question of the examiner. Very nice to see Dr. Sai Pooja. Pooja, you need to click on the video in order to listen the voice, right? So please punch Pooja into the chat, whether the voice is loud and clear. Very nice to see Dr. Venkata Lakshmi. Excellent. Yeah, please punch Pooja. Is the audio clear? Yes. Now let us look into the metabolic disturbance associated with sarcoidosis. Typically, it is the hypercalcemia, right? So the high calcium levels will also lead to hypercalciuria. And typically, how do you differentiate sarcoidosis with hypercalcemia from that of the hyperparathyroidism? Is a very important question. Hyperparathyroidism is high PTH plus high calcium, whereas sarcoidosis is a low PTH with high calcium, is what you need to basically remember. Whenever refractory hypercalcemia is there, how do you treat it, doctor? By using the biphosphonates is what we should remember. Very nice to see Sai. Please tick on the video so that you can be able to listen the voice, right? Activated granulomas in sarcoidosis can produce which active D metabolite? Actually, this question is little ill-framed. Yeah, so let's go to the next question. So basically, it is the 1-alpha hydroxylase which is being excessively produced by the activated macrophages in sarcoidosis. which is responsible for the hypercalcemia, is what we need to basically remember. Now, doctor. Anthracosis results from the inhalation of which particulate matter? Very easy question. I'll only give 10 seconds whenever it is the easy question. Nice to see Sai Pooja, Venkatalakshmi, Sai, Shastri, Satvik, Suresh Kumar, everybody. Yes. So, doctor, you should know that coal dust is the one which is responsible. Satvik and Venkatalakshmi, Sai Pooja and Sai, all of you correctly answered. Anthracosis typically causes the accumulation of the carbon in the macrophage. And typically, the anthracosis will make the lungs into black colored soot filled. That is the only pathology finding that need to be remembered. Now, doctor, Velcro like crackles which are heard at the lung bases are characteristic of? Easy question. Velcro crackles are a feature of interstitial lung disease. Where do you see interstitial lung disease among all of this? Is the question. Right? Now, let's see. How are your answers? Only Dr. Shastri correctly answered. It is the scleroderma which lead to the development of the interstitial lung disease. You can see how many times the questions are coming in the same topic. Now, whenever interstitial lung disease is there, what is a very important sensitive parameter? It is a decreased diffusion coefficient of carbon monoxide, DLCO levels, right? Scleroderma is autoimmune disorder that lead to pulmonary fibrosis, and we do the spirometry to document that restrictive lung disease whenever there is any interstitial lung pathology. And nintedanib is a drug of choice for interstitial lung disease. Increased TB is a risk whenever which disease is there. So you should know it is the silicosis. In fact, the name itself says it is silicotuberculosis. Satvik is absolutely right. Now, typical lung zone which is affected in silicosis. Silica hota hai zameen. Magar upper lobe involvement is very common. Axial calcification of the hilar lymph nodes is the classical feature which you see in case of the silicosis. And silica particles stimulate TNF alpha is what you need to basically remember. Very nice to see Manasa and Priyanka and many more who are all online. रोज मिलेंगे रोज पढ़ेंगे एक दिन कामयाब होके दुनिया को बताएंगे भाई मेरा नंबर आ गया. Consistency is important, doctors. I will be there for you every day evening 6 to 8, at least 150 to 200 PYQs we will do the revision. All right, doctor. So, yes, which are the following granulomatous disease, cause of the granulomatous disease? So as all of you know very well that hypersensitivity pneumonia lead to the granuloma formation. Satvik is the only guy who answered correctly, plus 4 marks. So non-caseating granuloma, sarcoidosis, fungal infection that lead to pulmonary granuloma, histoplasmosis, occupational disorder that lead to granuloma, berylliosis. These are all the facts that you need to basically remember. Right, doctor? Now, which of the following is not a typical feature of interstitial lung disease? Not a typical feature of ILD is the question. Priyanka, Venkatalakshmi, Sai, Shastri, Satvik, please punch. Is my audio clear? there is one small icon, chat. You can click on that and can be able to chat, right? Please punch is the audio clear so that I'm reassured that all of you are having a good broadcast, right? If you look in the desktop, you will get a bigger picture. Even in mobile, it is convenient, whichever is good for you. Yeah, you can give it a try. Thank you, Priyanka, Sai, Satvik. Now, which imaging modality very sensitive for early interstitial lung disease? HRCT. Interstitial lung disease by nature is restrictive lung disease. Pirfenidone is a drug which is used in idiopathic pulmonary fibrosis. And long term, they will be requiring supplemental oxygen. And whenever FVC happen to decline, that's a very important indication that the patient is having a poor prognosis, is what you need to basically remember. Queen's test historically helped in which disorder is the question of the examiner. Punch your answer, doctor. Queen's, very easy question, right? Now, all of you know, easy question. Satvik rightly answered. Sarcoidosis is the answer. So, uveitis, sarcoidosis. Methotrexate, sarcoidosis. Infliximab, sarcoidosis. Transbronchial biopsy, sarcoidosis. Facial nerve involvement, sarcoidosis. That's how you need to remember all the essential buzzwords. So I will give you the PDF that contain the 10 points for every PYQ, for 10,000 PYQs. Some amount of repetition will be there, but that there are the key points you need to remember like a flashcard for the tomorrow's NEET PG exam. Now, obstructive lung diseases. All of these, which one is not an obstructive lung disease? Easy question. Yeah, it came. Oh. Multiple times when next is clicked, it is pushing forward. Sorry. Now, which investigation of choice for detecting the lung fibrosis very early? Come on, punch your answer, doctor. For detecting the lung fibrosis very early. All of us order every day in and day out in the hospital, right? Right. So it is the high resolution CT scan. Venkatalakshmi, Satvik are absolutely right. Now, so you should know the total lung capacity in pulmonary fibrosis is usually decreased. FEV1 by FVC is either normal or increased in restrictive lung disease. So you should know differences between restrictive and obstructive lung disease. Then asbestosis is an interstitial lung disease where you see pleural plaques is what you need to remember. Now, which of the following is not a typical feature of emphysema? Sorry, that formatting didn't come well. All right. So let's go to the answer. Yeah. So now, what type of respiratory failure you see in emphysema? Type 1. There is a hypoxia with a normocapnia. And smokers may, there is a centri SNR emphysema. And because of hyperinflated lungs in emphysema, diaphragm is flattened. And we need to give long-acting beta-2 agonists like salmeterol in the treatment of COPD. But any day, the bronchodilator of the choice in the COPD is anticholinergic. That is the ipratropium bromide is the treatment of choice. Now, what condition is a common cause of a type 2 respiratory failure? Once more, sorry for the format. Yes. So we should remember some facts. When do you call type 2 respiratory failure? The moment PaCO2 is increased more than 45, when there is a hypoxia. And in type 2 respiratory failure, all that excess CO2 will convert into acid. That's the reason you get respiratory acidosis. And the rising PaCO2 will lead to development of somnolence and altered sensorium. So these are all the features to be remembered. Ayo. All these formatting didn't happen properly. So vital capacity is defined as a maximum air expelled after maximum exhalation, after maximum inspiration. That's a point you need to appreciate, right? Now, so what is vital capacity? So it is the sum of tidal volume, inspiratory reserve volume, plus expiratory reserve volume. Now, whenever there is any obstructive lung disease, if you calculate the VC, vital capacity, it is the one which is affected. So that is a point you need to remember. Similarly, in adults, as we keep aging, the vital capacity decreases, right? And you need to know, you give me 10 minutes time, 5 to 10 minutes, we will try to repair the MCQ structure and look, and then we will rejoin. All right, doctor? Oh, no. Type చేసి
Sorry,
Next.
స్టేట్ టేబుల్ మొత్తం క్లియర్ చేసి స్టార్ట్ చేయాలి.
అబ్బా నువ్వు అందుకోసమే చేయలేదు.
మీ ఇష్టం. రెజ్యూమ్ నెక్స్ట్.
నెక్స్ట్.
Go back. You are in a stale room.
Stop. Stop alert. Stop live. Here, what is a common cause of type 2 respiratory failure? Where you have hypoxia with hypercapnia. Please tell that the session resumed. Yeah? Ask Mary to inform students. So type 2 respiratory failure. Give me your answer, doctor. So we need to know the types of respiratory failure. Whenever chronic bronchitis, which is generally a type 1 respiratory failure, whenever there is any exacerbation, right, then there is a likelihood of going into type 2 respiratory failure. Now, the vital capacity is defined as maximum air which is being expelled after maximum amount of inspiration. That's what we need to remember. So it is the maximum exhalation after maximum inspiration which will give you the vital capacity. By definition is what we need to remember. Can you please ask her to inform? Then NEET PG 2016 question. Whenever there is any chronic pulmonary disease, CO2 narcosis in ICU, right? So what is the underlying cause, doctor, which lead to CO2 narcosis? Yes. So we need to know that it is the emphysema which lead to CO2 narcosis in the ICU. So acute hypercapnia, whenever it is there, it lead to cerebral vasodilatation. It lead to confusion. And we do non-invasive ventilation without passing endotracheal tube in order to support this subset of patients. Now, chronic bronchitis, by definition, requires productive cough for more than 3 months. For how many consecutive years, doctor? For at least how many consecutive years? Let's see. It is 3 months in at least 2 consecutive years is what you have to basically remember. Now, who is called a blue bloater? It is the chronic bronchitis phenotype is called blue bloater. And submucosal mucus gland enlargement in the airways is the classical feature. Exacerbations are often due to H influenza. And what is that? Mucosal thickness, Reed's index, which is being increased. And prolonged hypoxia stimulates erythropoietin that leads to the development of polycythemia is what we need to remember. And we use a beta agonistic agent, typically a long-acting one, to bring the bronchodilation. According to the Gold, very severe COPD is defined by which FEV1 threshold? Yes. Very severe COPD, what all that defines is a very important question. Nice to see Dr. Shastri. Yes. FEV1 by FVC less than 0.7 and FEV1 less than 30% predicted defines the severe form of COPD. So we need to give annual vaccination of influenza to every COPD patients. And if smoking is stopped, COPD progression will also decrease. And what is the target PaO2 to reduce the mortality by giving the home oxygen therapy in the COPD patients? Less than 55 millimeters of mercury is what you need to remember. Now, doctor, which criteria defines a persistent airflow limitation in COPD? So we need to remember, yes, fixed ratio threshold to define airflow obstruction is less than 0.7. And We use the long-acting LAMA, muscarinic agents. So, ipratropium bromide, etc., are the muscarinic agents that we need to remember. Now, so whenever FeV1 is 1.3 liter, FVC is 3.9 liters, what is the ventilatory defect? Is it restrictive or obstructive? So we need to remember it is the obstructive lung disease. So we need to know differences between restrictive and obstructive lung disease. So FeV1, after giving bronchodilator, if it increases to more than 12%, or if it increases more than 200 ml, that is an indicator of a bronchodilator response, is what we need to remember. And reduced FVC with a normal to high ratio of FeV1 by FVC is an indicator of either obstructive or restrictive. You need to be very sure. Now, alpha-1 antitrypsin, how does it provide its pulmonary protective effect? So it is the elastase which is responsible for the destruction of the lung, and it is the inhibition of this elastase prevents the destruction. So whenever alpha-1 antitrypsin deficiency is there, which part of the lung is involved, doctor? Lower lobes of the lung are the ones which are predominantly involved, is what you need to remember. And we use nephelometry in order to quantitate the alpha-1 antitrypsin levels. Right? Now, what is the correct statement about COPD physiology? How do you diagnose the COPD? So we need to know, after giving bronchodilator, when the FeV1 by FVC ratio is less than 0.7, then that is an indication of a COPD physiology, obstructive physiology, rather than a restrictive physiology. So whenever FeV1 is 45% of the predicted value, what is the gold stage called as? It is called as a severe gold stage. And what is the effect of emphysema on the diffusion capacity of the carbon monoxide? Typically, it causes a reduced diffusion capacity of the carbon monoxide, is what we need to remember. And when do you require the long-term oxygen therapy in the home, especially when the PaO2 is less than 50? Now, what is not a typical feature of bronchiectasis? Who is going to give me the correct answer, doctor? Bronchiectasis. Bronchiectasis is the dilatation of the bronchi. There is tons and tons of productive cough, right? Now let us see. Good. So it is the hemoptysis, chest pain, productive cough. Anything can be there, but not the night sweats in case of bronchiectasis. Now, whenever there is an advanced bronchiectasis, it is the Pseudomonas, which is the organism which stays. And what is the HRCT appearance in bronchiectasis, doctor? Tram track appearance is the classical feature. And situs inversus with bronchiectasis, where do you see cartogenous syndrome? So these are important points that you need to basically remember. Now, what is the best method to know the total lung volume in presence of large emphysematous bullae? What is the best test? See, basically emphysema is associated with increased residual volume. Spirometry cannot be able to test it. So what is your answer, doctor? It is called the body plethysmography, which is used in order to find the Total lung volume whenever there is a large emphysematous bullae is what we need to remember. So with this, we call it a day, doctors. Every day we will try to have initially at least 1 hour of session, and slowly as the students accumulate, we will try to increase it. Good luck.